Hi there, my name is Prag. I'm going to be talking about surgical site infections and how to combat them using a surgical antibiotic prophylaxis. So what is a surgical site infection? Well, it's essentially an infection that occurs after surgery in a part of the body where the surgery took place. To offer you some context, based on hip and knee replacement operations that resulted in SSI in 2006 to 2008, Australian study showed an increase of 27 days in the length of stay at a cost of 4.6 million. This was across 126 operations. Auckland DHB in New Zealand, across 11 operations, showed 42-day increase in loss at a cost of $451,000. This is based on the NZMA journal. So how do we prevent SSIs? Well, it's pretty simple in some respect. It's about administering the right antibiotic drug of the right dosage at the right times. And when we say right times, we're talking about before, during, and after surgery. So what you see here is the SAP guidelines. As you can see, it's quite complex. A clinician would use this to determine a drug regime. You would also use it to audit, to measure compliance by looking back. So from the guidelines, I identified the key dependencies. SAP is really dependent on patient variables like the weight. Has the patient got allergies? The MRSA flag. And then some surgery variables like the procedures involved. How long the surgery is going to take. So what you see here is a very simplified process flow diagram of how a drug regimen is developed. The clinician would obtain the patient's perioperative weight and then go on to find out if that patient has any allergies, check if the patient is MRSA infected. If the patient is, they would simply add a different set of drugs to the regimen. They would then identify what kind of surgical operation the patient is going to go through. And from there, using the SAP guidelines, identify the drug quantity and dosage, and then administer that before, during, and after surgery. In reality, that process is very different. We're now looking at the process from a perspective of auditing it. So if somebody wanted to find out if the correct drug regime was administered, this is what they would have to go through. They'd firstly use the patient's NHI to identify the drug product, drug dosage, and date of time of drug administration. Also use this to find out the date and time of the operation and any allergy data in the hospital's anesthesia administration system. At DHB, it's called Safer Sleep. They would then look up the NHI and check if the patient had an MRSA flag at the time of drug administration in the hospital's patient administration system, CMS. They would then look up the NHI and the hospital's theater management database, PIMS, and identify all relevant surgeries performed using the date time of operation. They would then use the NHI to check if the patient had an MRSA flag at the time of drug administration in the hospital's patient administration system. They would then use the patient's MRSA, allergy, and surgical operation data to determine if applicable drug products, drug dosage, and redosage rates from the SAP guideline chart were followed. For each drug administration at the time of surgery, they would determine if the drug product was correct, if the drug dosage was correct, if the drug product was administered in the correct time. They would use the surgery start date time as a reference point. And if the surgery lasts more than 4 hours, they would repeat 6A, 6B, 6C again. What we show here is the domain model. All the yellow boxes are processes. all the pink boxes are data points. As you can see, we've illustrated how a patient's NHI would be used to connect to different systems and collect data, determine something, and feed this into other processes to determine other pieces of data. The key thing here is how the different variables are discovered. Why is this whole process so difficult? Well, there's dynamic parameters. The patient's weight can change. The patient's MRSA flag can change. For example, the analyst must check if the patient was flagged at the time of drug administration. SAP guidelines can completely change. For example, during an outbreak situation, they would be very different. Then reconciliation. Now, drug products can be a combination of 2 or more drugs. They can also be administered in sort of smaller doses. So the analyst must then go and check if the total dosage in a specified window of time matches the prescribed dosage to meet compliance. And lastly, and this is the issue at most DHBs, you have multiple disparate source information systems. This means your data doesn't really connect, and you're left with sort of a heterogeneous data set. Now, how could a DSS support these SAP processes? Well, it would automatically determine the right drug regimen based on the planned surgery. This would lead to reduced specialist FTE resource to plan, qualify these drug schedules. Number 2, it ensures the right drug regimen is being administered. This would reduce human error. It would trigger alarms if non-compliant drugs were being administered at the time of surgery, or not enough drugs were being applied at the time of surgery. And then it would provide automated compliance reporting. This would lead to reduced FTE resource to perform this audit and compliance procedures. We could also derive metrics to help drive processes and behavior change. Further improve compliance by identifying where and when drug regimens were not administered correctly. The rationale for this whole DSS would really to just reduce harm caused to patients by SSIs. Reduction of SSIs is also a national health and quality and safety initiative, SSI program. Compliance data is currently limited. From what I understand, it's based on a sample of 10 to 15%, purely because performing the audit is such a complicated process. By reducing SSIs, you would see reduced readmission rates for DHBs. There's some key limitations. Data quality is a major one. Currently coded data is only available 28 days after the surgical event. To provide proactive or interactive alerts and alarms, we would need to rely on theater data, which includes unqualified surgical procedures. Secondly, integration. Real-time integration between disparate systems is difficult. We could possibly use robotic process automation or different technology to integrate systems like Safer Sleep, which is our anesthesia administration system, the CMS, our patient administration system, and PIMS, our theater management system. Lastly, semantics. When we enter data into our systems, they're really around ICD surgical procedure codes. However, the descriptions in the SAP guidelines are quite vague. We would need to match those to ICD codes for this to be any use.